Thank you, everyone. Those were wonderful talks, and I really appreciate your time coming here. So now we will open up to the committee for questions to the panel. Tracy suggested that if you wanted to ask a question, you could turn your card up like this so that I don't have to keep scanning for people raising their hand. So go ahead, Bob.
So all great presentations. So do I call you Nico? That's Nicholas? Yes. Nico. So I have two questions for you that are slightly different. I might have missed it, but what's the conventional wisdom on why the incidence rate is dropping at 2.5 or 2.4% per year? Sounds pretty good. Are we being successful at something, or is it happening despite ourselves? That's the first question.
Oh, can I have the other question first? No.
Yeah.
Well, we have, well, so in that paper that Chris showed, that there has been kind of a general downwards trend, and then like an overlay after the WHI decision. So we have discussed that underlying trend quite a bit, and we were really thinking hard. So looking at the risk factors, it's certainly not more parity. I mean, that's something that there's maybe more OCUs in that manifests in that period of time. So there are a number of theories, but it's clearly there, and we don't have a perfect answer to that. I mean, OCUs might be one explanation that comes in and just takes several decades to manifest in the population.
Has there been any consideration by your group of addressing this question to the CISNET modelers?
Yes, I mean we don't have concrete plans at the moment, but we have started talking to them on other female cancers, and we're now moving towards ovary. I mean there's cervix where there's a lot of work in CISNET going on, and we want to use that to move towards other female cancers.
Different type of question, but when you got to inflammation, I was hoping that there'd be more homogeneity in the effects. But it seemed like even with inflammation, you were seeing heterogeneous effects in different subtypes. Correct me if I'm wrong on that. But as opposed to the other lifestyle factors, where it's easier to understand that there would be differences in effects by subtype, when you get to inflammation, you're talking about a mechanism. And does this help us understand the role of inflammation in different subtypes, or has it sort of gotten that far yet?
Yeah, I think that's an important question, and I view, I mean, inflammation is extremely complex, and the markers we look at are only a tiny snapshot at one time point of inflammation, and like CRP, which is most commonly found associated with a variety of cancers, is like an end game of inflammation, and you can have many different starting points that lead to CRP being elevated. It's also not very specific for ovarian cancer. So I think that there are inflammatory processes happening at different parts in the female genital tract. I mean, we know that there's pelvic inflammatory disease that affects the tubes, and so inflammation there could have a very specific effect on like priming tubal cells, or to be more susceptible to transformation. Then we have incessant ovulation that could have an inflammatory pattern, but more affects the ovarian surface, and we have endometriosis that affects a different tissue type. So I think inflammation may play a role at different sites, but may have very different pathways associated. So I'm actually happy that we see differences by those subtypes, because it allows us to look more specifically and see, okay, so what do we see for serous? What should we look for in the fallopian tubes? Can we measure, for example, even infection in the fallopian tubes and see whether there's an early event that we're currently not considering?
Yeah, a couple of questions. With respect to looking at populations and breaking them down into subtypes, what about racial ethnic distributions and their impact on the different subtypes, and for that matter, on the genetic profiles that we pick up because of the known distribution of SNPs that are either population specific or ancestry related?
That's a good question. There is certainly heterogeneity of the subtypes by race and ethnicity. We know that Asians have slightly different profiles, and there's some data on African Americans, although that could partially be confounded by treatment and by survival. But I think the question related to genetics is difficult because most of our genetic studies are in Caucasian, so we don't have really good data on the genetics in those other groups. So it's a challenge, and there is actually a consortium on ovarian cancer in African Americans that was recently established by Joanne Schildkraut that is looking at this in one group. So there's a lot of work ongoing, but with ovarian cancer being so rare, if you split down subtypes and then look into ethnicity, I mean, you're running out of samples in most studies. Yeah.
My second question is to Martin. So taking the imaging paradigm to the in vitro system, there have been a number of papers looking at cytology, tubal lavage, oftentimes collected in from the peritoneum. But, you know, gynecologists are pretty clever in using small scopes and putting tubes into tubes and sucking stuff out. Is that a sort of a equivalent of a reproductive tract colonoscopy and or yeah.
So people are looking at, there's a colleague, Jason Bielas, is looking at like a cervical swab and look for circulating p53 mutations, for example, in local thing. And there's even a guy who was once at the Canary Foundation that had this fund to do this thing about trying to, how could you actually make a remote device that could be implanted that could swim up through the tube and take a little brush and return with a little, so all these things could certainly take place. And you know, I just kind of said there might be some technological approaches to it, and I think that, but you know, it's only by analogy that one says, well, all the current ones that work by direct visualization or sampling, so maybe that's the way to go. And it's just purely analogy, but it seems like you know, I would put that in the same ilk of like we need people who can look at these exotic things, but also recognize their job is to try to use them, and also be the part that will abandon them if they don't work, because we don't really need technologists. We need people who actually understand how to use technology. And I think that's it's a kind of a field of like computational biology did this, like how do you get people who actually have both computational stuff but also dedicated to biology research? And we don't have a lot of those people in the technology area who kind of live in, who straddle that gap. And I think that's kind of maybe the theme, what I think is really a possibility.
And if I can add to that, we're conducting a study with McGee's Women's Hospital, so with Dick Guido there, where we sample the fallopian tubes with a little tiny brush, and that has been very successful in getting out cells, and that kind of is a different way of getting a full representation of the lumen.
That's an abdominal approach as opposed to
the moment. I mean,
transcervical. Yeah.
Dr. Carlin?
Part of it's been covered, but I think one of the things that we stressed earlier again is that ovarian cancer is really multiple diseases. And so getting back to what Bob was starting on earlier in terms of trends, when we see the decreased trend that many have quipped that, oh, it's just use of OCPs, was it across all histologies? I guess that's the first place I'd start, but Nico?
Well, the trend has been observed for the major histologies, but they're also associated with OCU, so there's really not
But the mucinous was not. So is mucinous relatively increased in light of the others going down?
I will have to get back to you on that question.
And I guess along that same line of different histologic subtypes, I mean, my optimistic friend, Dr. McIntosh there. I mean, you know, 2/3 of the lethal ovarian cancers are serous subtypes, but clear cells, the majority are stage 1. And while theranostic approaches using nanoparticles that could then be used as a therapeutic as well as a diagnostic might be what we need to hold out for serous tumors, what about other imaging modalities for the 30+% that are non-serous? And do we have any new toys to use in that direction?
Well, you know, again, it's not really my area of expertise. I'm trying to like work with people who use them. I think the question might be is if you think of the world as being a bunch of different tumors, having a tumor-specific way of solving every problem may actually eventually become ineffective. And I did this thing once. I looked in the TCGA data and I said, well, how many this project where we're looking at like 30 over cancer, we have like 30,000 novel prevalent variant transcripts. And we kind of filtered them all down and found 6 that are actually not an artifact or something prevalent in some somatic tissue. But it turns out of those 6, 3 of them are actually in ovary and lung and colon, right? So it doesn't say that they're variable targets. It just says that there might be enough things unique across multiple tumor types. The way to do this might be to find out what those minor tumors are, find out what other types of tumors are there that might share that variant. You know, it's I don't know how many tumors there are, especially for like some of the imaging. Since these things, we take these probes, you can direct the stimulative thing into a specific region. So it's okay if it's actually part of the heart if it's looking at a cancer over here. So I think the way I may be doing is even thinking of like I was going to submit this EDRN grant before I got appendicitis and couldn't submit it the day it was supposed to be submitted. But I realized my grant was actually about looking across multiple tumor types and developing imaging markers that was shared. And there were plenty of them. And I think the way to do this would be that maybe our way of focusing on cancer site might actually be becoming a bit problematic as we start dividing up into smaller lesions. And I don't think this kind of means that high-flying thing, oh, look at KRAS cancers. I'm being a bit more functional. Like, just empirically, what are all the cancers that have a reasonably shared number of potential things to develop these things to? And then it's like microenvironment and things like that. That might be a way to approach it instead. Partner up with some other disease type that has a small minor, pancreas cancer. They're kind of really screwed, I think, because of their low incidence.
Nick, just to go back to the subtyping issue a bit further, some of the associations you reported related to serous. Among the serous tumors, about 10 to 12% are likely low grade, which etiologically are very different compared to the high grade serous. Do you feel like that, number one, that there are enough, that the data are good enough to differentiate between the two? And the second question then along those lines is that, historically now it seems like that the number of purely ovarian mucinous tumors, the numbers are actually decreasing, in part because a lot of what we thought were ovarian ended up being appendiceal. So are some of the associations really pure for ovarian, or could they have been confounded because they were actually GI tumors?
So I think regarding the low-grade serous cancers, they are a small group among the serous, and in our consortium, the data on grade, unfortunately, is not great. So we are somewhat limited there. We would like to pull them out, and we're working on that, and we might even go back and get some, I don't know, some rereads within individual studies, but at the moment, our data didn't really allow us to split out the low-grade serous, which we would definitely like to do. We took it as a, we focused on the serous as a combined group, thinking that they're likely dominated by the high-grade serous, and so that's our current working hypothesis. Regarding the mucinous, I agree. I think part of the decrease in mucinous, and I just looked it up in the paper, so mucinous decreased actually a lot more than the others, and probably partly because of the reclassification of GI metastasis. So the studies that we have mostly are from that transition period where we had initially more misclassification, and now we probably have less misclassification. So we are also working out to to find splits in the time period where we can probably look at a pure set of ovarian primaries versus other primaries. But I think those are both very important points. Yeah.
Yes, two questions. I think the first for Nico. On your risk factor slide from, I guess, the group of consortiums, the protectiveness of oral contraceptives and tubal ligation seem much lower than had been previously reported, which usually is around 50%. Is there an explanation for that?
So the OCU's data I showed was a continuous measure, so it's not I mean, you're probably more used to seeing ever never use, and that is very comparable to those risks that I just showed the continuous measure there. And tubal ligation is based on a small set of studies, and again, those are all cohort studies, and there may be some biases in case control studies where a lot bigger numbers are reported from. Yeah.
And
There also may be some attenuation of effect of premenopausal exposures over time, and the cohorts definitely, on average, have older cases than the case control studies. So that's another potential reason that you see slightly attenuated associations among the older cases.
nice. And then for the other two speakers, all the novel imaging and the screening, you said it's very expensive, $250 million. The nanoparticles are expensive to develop, and if you use gold, it's probably more expensive. So is it realistic that if we can develop these imaging approaches that you could actually use them in a cost-effective manner where, the cost-effective blood tests that are not effective now, are reasonably priced, but you can imagine a sonography itself, has some cost. Now you add expensive nanoparticles. What's the realistic?
I'm not an expert on the economics of the cost of these things, but I think in the end, a lot of times the cost of a medical procedure, the actual material itself is kind of often minor. But I don't know, what's the cost of a lifetime of blood tests every year, with a certain rate of follow-up for positive tests requiring more other intervention, and I don't know that answer. This would be something that happened one time, right? So if it's supposedly it takes $20,000 to do, even if it was that much, I have no idea what it is, if it's a lot or little. Well, how much would it cost over a lifetime of a woman being screened all the time? I really have no idea. So, and I really say it without anything, but it turns out, and so I don't know how expensive they are, what the economies of scale would be if they get manufactured. This would be something for some company to tell you what they are. I bet Sam Gambier or others who are in the nanoparticle field. NCI has a nanoparticle evaluation facility as well. They might get a sense of what they would need to be manufactured in large scale. But other than that, I don't really know. But
it's an excellent question. I can speak to the NLST as an effective screening test. We negotiated for a price of $385 per low-dose CT, which was both the technical and the professional component. It was Medicare price at the time. Medicare has subsequently, at least in the Vermont market, lowered their reimbursement. So that's one approach to controlling costs. The $256 million was for the conduct of the study. There was a cost-effectiveness analysis published by Bill Black from our NLST group this past fall in the New England Journal of Medicine. His analysis, including all the costs of imaging, the costs of the follow-up imaging for the false positives, came out to approximately $80,000 per quality-adjusted life year gained, which is considered within reason for the United States for a test. So I think it's really dependent on the technology and also what the insurers choose to reimburse.
I have a question for probably Chris, or maybe Marty would want to weigh into. You made it very clear the cost of running these big screening trials. In your opinion, is there any way to get an answer to the question of whether a screening modality is effective other than doing a randomized trial, either through non-trials or some more efficient way to do a trial to make it less expensive?
Well, I think you've just given me a segue into advertising a symposium that's going to be at the NCI on June 16th. And one of the issues we're going to be discussing, I'm moderating a session on, are there other approaches than randomized clinical trials? And I'm definitely going to bring up screening. I think this is critically important. I think if the UKC tox shows a small benefit, I personally do not think we need another randomized trial with a placebo control group. So then the question becomes, how do you improve on the existing screening technologies? The same thing for low-dose CT. We don't need another placebo-controlled trial. If an intervention is highly effective, like the risk-reducing salpingo-oophorectomy is so effective, you don't need a randomized trial of that. So it's in the gray zone where there's only small benefits, where the RCT gives you a precise answer. If you don't want a really precise answer, can you deal with something that's a little less precise without the randomized trial? I personally think so, because these things are hard to run.
Just want to follow up one point on that. Of course, with the lung screening, there were initially groups that had done single-arm studies and had claimed there would be these huge reductions in mortality, yet there were people who didn't believe that was really going to be the size of the reduction. And we did the trial, randomized trial, and found it was closer to 20%, and people might argue about why that was. But that's where it gets very difficult, because people get interested in the idea of using a technology or even doing a trial because there have been some dramatic estimates put out there. So I don't know if you had any comment.
Yes, I think that the initial results from the group that claimed an 80% 10-year disease-free survival did not have full follow-up of their cohort, and there were some issues with the number of deaths that were being reported, and also with staging. So I think that there are issues with one single very small observational study that you can't really generalize to the whole population. But I think that we need to really, that's why we're having the symposium. I mean, we really think it's critically important to look at new arenas and how we can use our statistical, pessimistic statistical colleagues to inform this debate.
So the question that we could mind was the trial. And so right now you think, well, right now the default is nothing. And then the trial in UK works, oh, the default will be that. But another one would be the default is, do you want to randomize people to have their tubes out versus not? That probably isn't acceptable quite yet, but it might be someday. And then the question about looking at how hard they are, because you want to affect death, not detection. And then, well, how do you know, for example, that a therapy that's improved doesn't actually cure those cancers that were actually in the trial detected early, right? I mean, so the thing is, it's hard. It's a long investment, and to make sure that actually it works now, but it continues to work as technology advances and changes. That's a very challenging thing. And when I was at the last Canary meeting, I made a comment. I said, well, if they work with those if it turns out that tumors that are very small can still be deadly like that, but taking the tubes out, well, if it works, well, isn't it now a public policy problem? Just implementing that as a policy. And so I said, well, no, it can't, because they don't like the invasiveness of the transabdominal procedure. But Sam Gambari just given a talk on his design to new transvaginal probe, and I picked it up. It was like the size of a bus. It was actually it was huge. It was very invasive. And so the question is, if one time out of every 10 years, you get this invasive test where you have this transvaginal probe that's going to be very invasive, definition of invasive. And I think it changed people's minds. So the question is, they're just, back I once saw this grant looking at how to deal with people with, uptake of cervical cancer screening among youths. And within a month after the grant was awarded, the whole thing about, look, prevention works. And this entire grant was awarded multi-million-dollar a year grant. Was all of a sudden it became irrelevant. And so the timescales are the one thing that are just kind of hard to cope. I don't have any, all I can really do is point out the uncertainty and the light and darkness. But it just is, the WHI showed us that it could have actually been true that before they started the trial, HRT did prevent heart disease. But it could be the changes in patterns already corrected those that were saved, and now what's left is the stuff that actually is risk-benefit trade-off. And so it's just hard to really deal with these things that, an intervention now that saves your life 15 years from now, those things are really just hard to assess, right?
So just to follow on that question, are there other endpoints besides mortality that we could try to look at?
The number of grants we get, that's a good.
There's a nice paper by Jack Cusick on intermediate endpoints in cancer screening trials. He looked at the Wendy Atkins colorectal screening with sigmoidoscopy. And you can actually look at stage shift and absolute decline in the numbers of advanced stage diseases, so to predict subsequent mortality outcomes. So that would potentially move the results a little earlier. I think that that's useful for a screening study.
One of the things I think is striking about the results, Nico, from the OC3 is the lack of really strong risk factors for serous tumors, which we know to be the most common. I mean, it's actually kind of surprising that the risk factors that we identified are mostly for non-serous tumors, which are less common. So how are we going to move forward to try to identify risk factors for serous tumors? Anyone on the panel?
Well, I mean, we've talked about that a lot recently, and we certainly haven't come up with a really good answer to that. But I think we like, first of all, by revisiting a lot of things that we looked at before, now with our stratification by endpoints, we may have a chance to pick something up that we missed before. I think that's one lesson that we learned here. Most of the associations we have found that were not picked up before were for the non-serous cancers, which is clear because in any combined analysis it's dominated by serous, but there could still be things that show up now that we have pure endpoints. And to the same point, if we really focus on the high-grade serous cancers and go through a whole array of risk factors, that makes sense. I think we also have a lot of good leads now based on the biomarker data, based on the risk factors. I mean, we have one strong risk factor that still holds up for serous cancers. That's menopausal hormone therapy. So there's certainly something that is strong and serous. So along those lines, is there anything similar? Can we come up from the biology that we understand better now and focus more on those risk factors? I think that's what I would say now. I mean, I don't have anything top on my list that I think we have missed, but I think we need to be very thorough and go back.
Okay. Just a couple of questions. One is, and this would be to Nico, what is the significance or explanation of the grade distribution among the histologic subtypes?
I primarily showed it to demonstrate that we could get away with not looking at grade in this study, because we have kind of the majority of the serous being high grade, and I think it's a reflection of different biology. I mean, there is low grade serous cancers that certainly have different molecular features than the high grade serous that probably derive from somewhere else. So I think grade is a not well reproducible phenotype of an underlying biologic process that we can try to understand better, and maybe at some point, hopefully, we can come up with a more with a less subjective molecular panel or approach that we can classify those biologic pathways. So I think it's a reflection of the biology, and some of the non-serous types are more likely to be low grade because they're more benign pathways, they're more benign clinical behavior. But again, there should be better measures for the underlying biology.
Okay, and just another quickie, if no one, well, somebody else does, but anyway. Relative to underserved populations and their participation in these trials that we're talking about, whether they're screening or otherwise, I know that Nico mentioned the consortium that is working with African Americans trying to get into the trial. Exactly how is that manifesting itself? How, other than getting data that we all know, quite frankly, that people aren't participating either because they're not invited or for other reasons, how are they interacting to make a difference, not simply to make a statement?
So I think the consortium usually starts with looking at data that's already out there, and then kind of focusing on those groups. I think with regard to new efforts, that's a very difficult area, and I think the consortium wants to move there, but at the moment that they're focusing on existing data. I think showing but I think even that could be a good starting point, showing that you're focusing on those populations, that you're getting awareness to underserved or minority populations will hopefully lead to more participation in the future. But I mean that's certainly not my area of expertise, and maybe Chris has a few additional comments.
Yeah, I think we should look at best practices, and within the PLCO, we've reported on groups such as our Colorado group that specifically over-recruited Hispanics and what things worked within that population in Colorado. At the University of Alabama, we had a very high participation rate of African Americans. They have a specific program as part of their cancer center core that deals with recruitment into their clinical trials. Yeah, I'm not sure what the name of it is, but it is highly effective. I'm very impressed by it. I got this one question of what should we do with the bus now that we're done with screening? I said, what bus? We had paid for a bus to go pick people up for their screening appointments, but and bring them to and from the clinic. It was not a very expensive bus. It was one of these used VW things. It was safe. And so we sold it. And so, but those kinds of interventions and learning from groups that have done real well, I think we need to build on their successes.
For that comment, because part of that is about acting on what we know, and we don't do that very well in certain populations.
Remembered what I was going to ask. So, is there any value in having a national biobank for testing biomarkers that could be applied? I mean, recognizing it would be retrospective, but to have it well characterized from well phenotyped subjects so that people who had novel ideas could at least determine whether there was a likelihood that the sensitivity, specificity, positive, negative predictive value is such that it would merit a test in a very expensive trial.
I think I actually find I've never really lacked for cancers and healthy controls in any study, because it turns out if you want something of the scale that people might need for early detection, it's a pretty big scale. You know, people say, oh, you need hundreds of things. No, like basically if you want percent sensitivity, 30 cases and 30 controls are pretty good to give you that big effect you're looking for if we have one marker. More if you use multiple markers. The thing that's hard is you can't get where's a random sample of people who happen to be have other type of conditions of people walking around. A lot of the studies will actually take people who actually have been cancer-free and other-free for a while. So what I think we need is actually a repository of everything else other than cancer, so we actually know, at least for blood markers, whether they're specific or not.
It's an excellent question. There have been attempts by previous NCI groups to set up virtual networks. The PLCO Biorepository and some of the other groups like the Women's Health Initiative and CARET that have pre-diagnostic specimens try to collaborate and increase power for their studies. I think that one aspect of the PLCO is that since it was a multimodal trial with large sample sizes of males and females and reasonable numbers of African Americans and Hispanics that got quite a number of diseases. It does serve as a very useful place to go for some of these complicated questions about, does your marker perform in colon, breast, and lung as well as ovary? So there are efforts to try to improve the networking.
And those samples are available?
The PLCO samples and the NLST samples are available. You can Google the NLST biorepository and the PLCO biorepository. The application process involves similar to a grant. There is money attached through a current RFA for PLCO samples, and so you have one review. And for the NLST, it's a little bit more. There's no money attached at this point, but it's open to the whole research community. And a plug for all of our data sets are completely available to the entire research community.
I mean, I think that there are resources out there, but usually the bar is rightfully so very high to get those, because those were expensive, large prospective cohorts. And having a resource with prospective specimens that is slightly less precious and would allow us to do some of our early testing there, rather than going either to case control studies that have serious limitations or to those very precious cohorts, would probably be very helpful, and would allow us especially to eliminate overly optimistic candidates from the race, and not have them go to one of those precious studies.
The question here about like a novel idea. So one of the things that I helped with this colleague of mine, Nicole, and also Beth, the repository of our spore. I think in the last couple of years, hardly anybody's asked for stored specimens. A lot of the new ideas need new materials, collected fresh material, like flow sorted or things like that. So there's a certain limitation for large biobanks, because a lot of the stuff isn't used. But I think that also the question about early detection of blood markers is going to recognize that just the challenge it is. So, I'm going to wave my hands here. So, we take hey, here's cases and controls. We look at different markers that are high here in cases, but low in controls, high. But then what happens is you're looking over time. And so this is the time dimension, this is the marker level, right? And so you say things are going to rise up. Well, what we do is we pick markers that look at this dimension, but what we want to know is how they go here. And there's no information here. And so one example about how this comes is when this EDRN spore project validated 70 markers, every one of them was 50% or more sensitive in time of diagnosis. And I wanted to actually test p53 autoantibodies. But it turns out it was only 30% sensitive, and nobody wanted to test it. So I tested on my own. I got WHI specimens in my freezer. But it turns out every one of those markers elevated only within 3 months of diagnosis, except for CO125, right? And HE4 a little bit, but not as much. It turns out the answer was CO125 on its own was the best marker, if you want this dimension. Except that HE4 matches it, because it was only 30% at diagnosis, but it was 30% 2 years before as well. So it actually didn't elevate. So the thing is, we don't know how to, we don't even know how to identify a marker that's worth validating. That's how challenging the problem is, right? That's pessimism.
Very quickly. So the PLCO collection and the NList collection, were they actually serial samples, or were they taken at baseline only?
Serial samples for both. We skipped T3 for some specimens within the PLCO, which was a mistake. And so there's samples over 6 rounds. For the NList T, it's for 3 rounds. And serial markers were studied.
Just a quick question about, as moving forward, as we're talking about biorepositories, what about the psychobehavioral, social repositories of trying to get a handle as we look prospectively, trying to tease out the influence of these different markers? Do you have recommendations of sort of the low-hanging fruit that ought to be included in these? Okay, sure, high-hanging, there you go.
No, I don't really know, I guess. I looked for low-hanging fruit, and I left the whole field. Right? That's kind of how I did it.
My opinion at this juncture is that we should not be mounting a large-scale randomized clinical trial in ovarian cancer. I think the cohort consortium is now getting to a point where they have a large number of cases, lots of controls, and can do many interesting things and exploratory things, come into the PLCO if they get some decent biomarkers. I think the nanoparticle imaging looks quite promising. I think other imaging modalities, I think we really need more work on these early detection modalities. And they could have ramifications beyond ovarian cancer, like pancreatic intraepithelial neoplasia could be another use for nanoparticles. And so I think we need more basic science research.
Great. Well, thank you to all of our panelists for great presentations and a very stimulating discussion.